Everybody to Geriatric Grand Rounds. Thanks for joining us this morning. A few announcements before we get to the presentation today. Our next Grand Rounds will be April 29th, and our presenter is Dr. Annie Gabrielski, PharmD, and she's one of our geriatric pharmacy residents, and we'll be talking about vaccines. Our next journal club is May 13th, and our leaders for that will be Drs. Azelby and Ahmed. Other announcements, after Grand Rounds today, you will receive an email with a link to the presentation and a copy of the slides, as well as a link to an online evaluation. So if you could please take a moment to fill that out and send it back, that would be very helpful. Please feel free to submit any questions during the presentation in the chat or the Q&A box, and we'll go through those at the end of Dr. Azelby's presentation. So I'm very pleased to introduce Dr. Azelby, one of our wonderful geriatric fellows this year. Dr. Azelby has an interesting background. She actually studied French and economics at the University of Virginia and was originally planning for a career in real estate. After a brief foray into commercial real estate in Manhattan during the 2008 recession, however, she quickly shifted gears and decided to pursue a career in medicine. She completed her post-bac pre-medical program at the University of Rochester and then returned to her home state of New Jersey, graduating in 2017 with an MD from Rutgers, New Jersey Medical School. She completed her residency training in internal medicine at CU. And then fortunately for us, she serendipitously tumbled into geriatric medicine toward the end of her second year of residency. She plans to continue her career in geriatrics in the Denver area, focusing on skilled nursing facility and long-term care medicine. In her free time, she morbidly enjoys true crime podcasts when she is not hiking and camping with her partner and two crazy dogs. So we're very happy to have you with us today, Chris, and she's going to talk to us about myelodysplastic syndromes in older adults.
Thank you so much, Carrie. Good morning, everyone. So I kind of put together a talk on myelodysplastic syndromes after a discussion with my co-fellows. We kind of all felt this was a black box. We didn't know a lot about it, but we know it happens in our patient population. So I took it upon myself to kind of teach myself as well as you a little bit about MDS in older adults. So the objectives of this presentation today are going to be just kind of understanding the pathophysiology of MDS, become familiar with the different subtypes of MDS as this kind of comes into play when we discuss treatment. And then I'm going to dive in briefly to the workup of macrocytic anemia and then how you ultimately can diagnose MDS, and then touch upon prognosis and some current treatments. So what really is myelodysplastic syndromes? So essentially, simply speaking, it's bone marrow failure. So you're going to have ineffective hematopoiesis. So it's going to affect the development of your red cells, white cells, and platelets. And this will affect the myeloid cell lines, which I will kind of get to in the next slide to refresh your memory. And typically you're going to see MDS presenting in older adults. They typically will have pancytopenia, but that's not always the case. Possible peripheral blasts on their CBC, peripheral smear, and they will have hypercellular bone marrow on biopsy. And I'll kind of talk more about this. And something to mention, MDS is actually can be considered a precursor of AML, which is acute myeloid leukemia. It shares a lot of clinical and pathologic features. But the one big difference between MDS and AML is that you're going to have less than 20% blasts in your bone marrow. And in about 30% of patients, MDS will convert into AML. So a lot of the treatment goal is to prevent the progression of MDS into AML, which is highly fatal. And then just kind of to make it a little bit easier to remember, kind of the word myelodysplasia. Myelo kind of stands for bone marrow, and dysplasia are abnormal cells. So it's abnormal cells in the bone marrow. So then this might trigger some nightmares for medical school for my co-fellows, but just to kind of remind everyone, so in the bone marrow, you have kind of this pluripotent stem cell that then will diverge into a myeloid precursor and a lymphoid precursor. So simply the myeloid precursor is going to give rise ultimately to your platelets, your red blood cells, your granulocytes, which are your eosinophils, your neutrophils and basophils, and then your monocytes, whereas the lymphoid line will give rise to your natural killer cells, your B and T cells. And so when we have defects in the myeloid line, this is kind of what gives rise to our AMLs, our MDSs, our CMLs, as opposed to the lymphoid line, which is going to cause your ALLs, your CLLs, your Hodgkin's and non-Hodgkin's lymphoma. And so what happens kind of in MDS is you're going to have mutations, both chromosomal and kind of somatic gene mutations that occur in these blasts. So you're going to basically have an inability to make healthy platelets, red blood cells, white cells, and monocytes. So you end up with this hypercellular bone marrow that's kind of full of these ineffective cells. So they don't differentiate, they're dysplastic, and they're really unable to mature. So this is why you'll have a hypercellular bone marrow, but you're going to have peripheral pancytopenias. And they've identified over 50 gene mutations involved in the pathogenesis of MDS. So these include genes that code for proteins involved in mRNA splicing, epigenetic regulation, and transcription. So it's kind of quite involved. And then also just a quick refresher, you have your normal cells, you have neoplasia, which is just excessive growth of cells, and then your dysplasia. So these are going to be abnormal cells that are improperly differentiated. So what causes MDS? So we don't really know. So in 90% of cases, which is considered primary MDS, it's some sort of de novo mutation, but we don't know what is actually leading to this mutation to develop. But then there's kind of 10% of cases which they consider secondary MDS, which are secondary to environmental exposures. So chemotherapy and radiation, tobacco use, and then also benzene can be a pretty significant culprit. And benzene is kind of a precursor for common synthetic materials like rubber and nylon. So it's pretty common, and at-risk occupations for kind of high levels of benzene exposure will be your chemical plant workers, your painters, oil refinery workers, paper factory workers. So a history is definitely key if MDS is maybe on your differential. And then there's a very small proportion of patients that have MDS secondary to an inherited condition like Fanconi anemia or trisomy 21, but we won't really be addressing that today. So just a bit of history about MDS. So it wasn't really considered labeled a disease until 1976. And originally the scoring system was the French, American, British, or FAB system. And you'll kind of see that system referenced quite a bit when you look at the literature. But then in 1999, the World Health Organization published a new classification system that replaced the FAB. And this was then revised in 2008 and then most recently in 2016. So I'll be going over kind of what the WHO criteria is and the different subtypes. And then in 1997, they came up with the International Prognostic Scoring System, or the IPSS. And this is basically used to classify the risk, really quantify the risk of progression of MDS into AML, as well as median survival. And they recently revised this in 2011, so we'll be reviewing the IPSS-R today. And interestingly, MDS was not considered a neoplastic disorder until 2001. And then just kind of some epidemiology. So the data from the National Cancer Institute Surveillance, Epidemiology, and End Reports, so SEER, kind of shows that 86% of MDS cases are diagnosed in individuals over the age of 60, and the median age is 76. So this is absolutely our patient population. And SEER also shows that the incidence of MDS increases significantly with age. So for patients for a population in their 30s, the incidence is going to be 0.7 per 100,000, and then that's going to increase to 36 per 100,000 after age 70. And there's even a 5-fold difference in risk just between the age 60 and for patients 80 and over. And there's probably it's estimated there's 40,000 new cases diagnosed with MDS per year. And I suspect as our technology gets better, that will definitely increase. And MDS is more common in men than women. So it has an incidence rate of 4.5 versus 2.7 per 100,000 population in men and women, respectively. So what is this 2016 WHO classification? So myelodysplastic syndromes are really a heterogeneous group of diseases. It's not just one disease. And sometimes you'll see it kind of written as myelodysplastic syndrome, but it really is an umbrella of syndromes. So kind of the WHO broke down different subtypes of MDS, and this is all based on the histopathology. So they have MDS with a single lineage dysplasia, MDS with multi-lineage dysplasia. And so that's basically just saying that in the different cell lines, so maybe it's just your red blood cells that are dysplastic in your bone marrow versus kind of your red and white cells being dysplastic in your bone marrow. Then there's this subtype that has ring sideroblasts, and this is actually relevant because there is a specific treatment for this exact type of MDS. And then there's MDS with excess blasts, MDS with isolated deletion 5q. So that's a deletion on the long arm of chromosome 5. And I will talk a little bit more about this because there's also a treatment specific for this type of MDS. And then there's MDS unclassifiable. So you have MDS cytogenetics, but you may not have dysplasia. So what do patients look like that have MDS? So they can have kind of all of the symptoms that would correlate with pancytopenia. So excessive fatigue if they're very anemic, bruising and bleeding with their low platelets, fevers, rashes, weight loss, and then certainly recurrent infections can also be a hallmark of the disease given neutropenia. And interestingly, fatigue is probably the most debilitating symptom of the disease and typically what patients will report based on a few studies. And once again, these kind of all correlate with which type of cytopenias they're presenting with. But then you can also see kind of patients that have this unexplained macrocytic anemia for a few years, which might be a sign that they have MDS. And we'll talk a little bit more about that. So then I just kind of wanted to diverge and talk about kind of what is macrocytosis versus megaloblastic anemia and MDS. It can all be very confusing and a lot of it overlaps. So I'm going to just try to simplify it for everyone. So macrocytosis is going to be an increased mean corpuscular volume, so an MCV greater than 100. And this is going to be the hallmark of really megaloblastic anemia. But you can have a macrocytosis, just an elevated MCV without an anemia. So that would be a macrocytosis. And there's a prevalence about 4% of macrocytosis, and about 60% of patients present without a drop in hemoglobin. And so I tried to find, what are the recommendations to work up an isolated macrocytosis? And there really aren't strong recommendations, but it's advised to kind of do the typical workup that you would do for a macrocytic anemia. And we'll talk more about this. And then I found kind of just interesting, there was a study of 300 hospitalized patients with macrocytosis, both with and without anemia. And the results of this study showed that 100% of the bone marrow disorders that explain the macrocytosis had a coexisting anemia. And then kind of just to briefly touch upon, megaloblastic anemia versus non-megaloblastic anemia, it can get very confusing when you're thinking of MDS. So I kind of like to break it down into reversible versus irreversible. But just to kind of remember or touch upon that megaloblastic anemia is typically associated with the vitamin B12 or folate deficiency. And you're going to see hypersegmented neutrophils on peripheral smear, as well as macroovalocytes. So these kind of big oval-shaped red blood cells. But you can also see those findings in MDS. So I find that to be a bit misleading. But megaloblastic anemia is a reversible form of ineffective poiesis. So this is your vitamin B12, folate deficiencies, can also be drug-induced, and I'll talk a bit more about that next. While MDS is considered an irreversible disorder of ineffective hematopoiesis, and this is going to be secondary to kind of mutations and chromosomal abnormalities occurring in those blast cells in the chart I showed you in the beginning. And so I just kind of, for this slide, and I apologize, it's very blurry, but I just want you guys to kind of focus more down here when we talk about kind of B12 deficiency. So we have a macrocytic anemia. We certainly want to check a vitamin B12 level. So vitamin B12, if it's less than 100, then you're pretty confident that this is likely a vitamin B12 deficiency, and you replete them and monitor their response. And then kind of here it gets a little tricky where their B12 is 100 to 400. So it's kind of borderline low. And here they recommend checking an MMA and homocysteine level. And this is going to help differentiate between a vitamin B12 or folate deficiency. Or if they're both normal, then you maybe want to start thinking about some hematological disorders and then a few other causes that I'll touch upon. But MMA and homocysteine levels, if they're both elevated, think B12. If MMA is elevated, but homocysteine level is normal, B12 deficiency. And then if your MMA level is normal, but your homocysteine level is elevated, think folic acid deficiency. Obviously, folic acid deficiency is relatively uncommon in the United States, given a lot of our food is fortified. But in our population, we do have kind of these tea and toasters who aren't eating, they're extremely malnourished and could possibly be folate deficient. And then kind of over here, another way to work up folic acid deficiency, you could consider an RBC folate. This is not something we typically do, but I thought it was worth mentioning. And this would be if your vitamin B12 is over 400, you still suspect this could be a vitamin deficiency. You can check an RBC folate level. So just to kind of go into some of the causes of macrocytosis and macrocytic anemia. So drugs can definitely do it. So HIV meds, methotrexate, since it's essentially a folic acid antagonist, kind of the azathioprine, cytarabine, a chemotherapy, then the anti-epileptics, nitrous oxide, and then Bactrim, metformin, PPIs, and cholestyramine. And I just kind of want to highlight those because a lot of our patients are on these medications. Then vitamin B12 deficiency, folate, copper deficiency can also do it. And the copper deficiency will typically occur in the setting of zinc overload. And then hypothyroidism, liver disease, hemolysis, COPD. And the theory here is that EPO causes excessive bone marrow turnout. So you're going to kind of have these larger, younger cells that are being pumped out, which will be a macrocytosis. And then, of course, alcohol. So alcohol can have just a direct toxicity on the bone marrow causing a macrocytosis. And then it can also kind of in your chronic alcohol abusers, you can have a coexisting B12 and folate deficiency. And then this was interesting that I didn't know is that there can be spurious causes of a macrocytosis. So you can see this in hyperglycemia and then a profound leukocytosis. So for hyperglycemia in the lab, blood gets diluted to kind of measure the mean corpuscular volume. And in the setting of hyperglycemia, you have kind of osmotic disequilibrium, the RBCs swell, and that will actually cause a false elevation in MCV. And then increased turbidity of a sample in the setting of a leukocytosis can also cause a machine to overestimate the size of the cells. And then I just wanted to also touch upon some MDS mimics or other causes of cytopenia to consider. So heavy metal toxicity, kind of exposures to lead, zinc, arsenic can kind of present looking like MDS. Alcohol abuse, HIV infection itself. And then there's aplastic anemia. But remember, this actually has a hypocellular bone marrow. So bone marrow biopsy will differentiate this, but I just wanted to mention it. ITP can look like this. Felty syndrome, which is your classic triad of rheumatoid arthritis, splenomegaly, and a granulocytopenia, so a kind of decrease in your white blood cells. CML can look like this. And then you have kind of these other classifications, and I didn't touch upon this too much in this presentation because it can get quite complicated, but you have idiopathic cytopenias of undetermined significance. So you have cytopenias, but you don't have dysplasia, and you've kind of ruled out all the other causes. And then you can have an idiopathic dysplasia of undetermined significance. So you have dysplasia, but it's not meeting MDS criteria. So now kind of your basic workup, when you've got someone with macrocytic anemia and you're maybe worried about MDS, so you're certainly going to want to get a CBC with differential. And if a patient truly does have MDS, you will see macrocytic anemia, typically with a hemoglobin less than 10 and an MCV over 100. They'll have an increased RDW. So they're just going to have all different sizes of their red blood cells on peripheral smear because there's usually a microcytic and macrocytic component. Leukopenia, so you'll see a neutropenia. Their ANC can usually hover around 1800 and a thrombocytopenia, but this isn't always the case. These patients can present with just one cell line that's low. You certainly want to get a peripheral smear, and I will talk more about the findings on that in MDS in a few slides. They do recommend a reticulocyte count in MDS. This is usually going to be decreased because remember, this is a hypercellular bone marrow with poor maturation. So if we kind of look back to that other slide, reticulocytes are kind of the last step before a healthy red blood cell. So if you're having genetic mutations occurring in the blast, they're never able to make it to the reticulocyte itself. And then we kind of talked about vitamin deficiencies that you want to rule out, B12 and folate. You definitely want to get a TSH to rule out hypothyroidism, LFTs to make sure they don't have liver disease. And if you kind of rule out all the usual suspects, then you're going to refer them to heme, and they should undergo a bone marrow biopsy with cytogenetic studies. And I just included this slide to show this is a bone marrow aspirate of a patient with dyserythropoiesis. So they have MDS, and kind of all these yellow arrows are pointing to abnormal erythroid precursors or abnormal kind of red blood cells. So what are we going to see on the peripheral blood smear of a patient who has MDS? So kind of like I mentioned before, there can be a single cytopenia. So it can just be an anemia, a thrombocytopenia, or a neutropenia. You can have a bicytopenia, which is 2 of those, or a pancytopenia where your red blood cells, white blood cells, and platelets are all low. And so the anemia will kind of usually show up as macrocytic. So this will be a mean cell volume of 100, like I mentioned. And then your red blood cells are going to be oval shaped. They're called macroovalocytes. And they also can contain the red blood cells basophilic stippling. And I'll show you pictures of all this so it makes a little bit more sense. And then the neutropenia, you'll tend to see kind of these abnormal looking granulocytes or white blood cells. And the neutrophils in particular, there's this pseudo-Pelger-Hewitt abnormality, which is characteristic of MDS or other hematological malignancies, where it's just a bilobed neutrophil, and I'll show you a picture of that. But you can also have hypersegmented nuclei. So these are kind of neutrophils that have multiple nuclei, and I will show you a picture of that as well. But this is also characteristic of megaloblastic disease, which is why I said it can be a little bit confusing because there's definitely a ton of overlap between the two. And then platelet counts are typically decreased. They are rarely increased, although there are subtypes of MDS that have thrombocytosis. But they tend to be kind of these large immature platelets that don't have any granules in them. So here kind of, these are going to be our macroovalocytes. So these are kind of these large red blood cells that are lacking central pallor. So you can kind of see more normal ones down here. And this also can be seen in vitamin B12. So it can be a bit confusing, but this is typically what you're going to see in MDS. This is basophilic stippling. So you kind of have these deposits around the nucleus in the red blood cells. And then this is just your increased RDW. So you've got kind of these little microcytic RBCs. You've got big old kind of macrovalocytes lacking central pallor. So it kind of runs the gamut. Then these are kind of your abnormal neutrophils that you'll see on peripheral smear. So this is a Pelger-Hewitt neutrophil. So it's bilobed, so it just has 2 lobes, as opposed to a normal neutrophil, which usually has about 3. And this is more characteristic of MDS. This is not really something you'll see with a vitamin B12 deficiency. And then you have your hypersegmented neutrophil, where you'll have multiple lobes in the nuclei. So, it'll be greater than 5. I think this has about 8. And then finally, our abnormal platelets on peripheral smear. So these are normal platelets and they stain. You can see the granules inside of them, and these are just a bit clumped. So it gives you kind of a good view of them. And these are going to be your abnormal platelets. So they tend to be large and they don't have any of these granules that are being picked up on stain. So essentially, platelets without granules are completely useless. And then interesting, kind of just going back to the increased RDW, I did see a study in the British Journal of Hematology that showed that an increased RDW in lower risk MDS patients, which I'll get to later, kind of what differentiates lower versus higher risk, but an increased RDW greater than 14.5% may actually portend a poorer prognosis, even though they're considered low risk MDS. So let's say you rule out B12, they're not hypothyroid, their liver functions completely normal. So you're going to send them to hematology and get a bone marrow biopsy. So if they have MDS, what's going to show up on that bone marrow biopsy are going to be myeloblasts, less than 20%. And this differentiates from AML because on an AML bone marrow biopsy, you'll have myeloblasts, but greater than 20%. So you can kind of think of MDS, like MDS is to AML what MGUS is to multiple myeloma. However, the big difference is that MDS is considered a precancerous state. I'm sorry, MGUS is a precancerous state. MDS is a cancer. You'll see hypercellular bone marrow. You'll see kind of cytopenias. And then you have to have dysplasias in greater than 10% of a single cell line. So 10% of your RBCs have to look abnormal, for example. Immature white blood cells and red blood cells, that's called leukoerythroblastosis. And then once they get the bone marrow biopsy aspirate, it will then be run for cytogenetics and next generation sequencing. And this will look for kind of an abnormal karyotype, so abnormal chromosomes, as well as kind of somatic gene mutations within the cells themselves, which is pretty cool. And I'll talk a little bit more about that as well. So I just kind of added this to give you an idea of how many chromosomal abnormalities they've identified. There's more than this. I just didn't have enough room on a slide. And so this, I just want to point out, because this is a specific subtype of MDS that's a low risk MDS. It's the deletion 5q. And there's actually a specific treatment for this type of MDS that comes up with these cytogenetics. And then these are a list of the gene mutations. And this will be run on next generation sequencing. This is just a few. There are way more than this. I just kind of included this to give you an idea of really how complicated it is. So now we've kind of diagnosed MDS in a patient, but how do we figure out their prognosis? And a lot of times I find that patients come to me that have cancer, not just MDS, and they kind of want me to help counsel them on what they should pursue. And so this will give you an idea of how you can really have this discussion with patients in a very evidence-based way. So when we're thinking of prognosis in MDS, we want to think about how severe is your case of MDS, how likely is your case to become AML, and how long are you likely to live? And these are actually questions we can answer based on clinical risk. And so clinical risk is going to be based on kind of your blood counts. So how severe and how many cytopenias do you have will correlate to your risk. the percent of blasts in the bone marrow. So do you have 5%? Do you have 10%? And remember, the closer you are to that 20, the higher risk you're going to be because you're that much closer to AML. And then they actually look at the type of chromosomal abnormalities. So the karyotypes, the chromosomal makeup of effective cells. And all of these criteria go into that International Prognostic Scoring System revised, so the IPSS-R. And then just to remind you, 30% of patients with MDS will transform into AML. And then next generation sequencing, which is not part of the prognostic risk calculator that I'm about to talk about. But these will identify mutations that respond to certain treatments and that may portend a better or worse prognosis. This is not included in the kind of current calculator of risk, but I suspect in the future it will be. So what is this International Prognostic Scoring System? So it's pretty cool. So they take the bone marrow aspirate, they run, they look and identify these cytogenetic abnormalities. And these are just kind of naming a bunch of them. So based on what your patient kind of, what they find in their bone marrow, and they might find nothing in terms of their chromosome, this tells us kind of what their prognostic subgroup, which prognostic subgroup they fall into. So if you have someone who has a deletion 5q in their chromosomes, this is going to put them in the kind of good prognostic subgroup. So then you take their subgroup. So based on their cytogenetics, our patient falls, let's say, in kind of the good group. So that gives them a point, and more points is worse. So we already have 1 point. And then they're going to look and determine how many blasts are in the bone marrow. So let's say our patient has 3% blasts. So that will also give them 1 point on this kind of calculator. Then you want to look at what is their hemoglobin. So let's say that our patient's hemoglobin is 9. This will also put them give them another point. So we're at 3 points. Then you want to look at their platelet count. So let's say our patient's platelets are above 100, so they don't get any points for that. And then you want to look at their absolute neutrophil count. So we'll say our patient's neutrophil count is holding steady. It's above 0.8, so that's also 0 points. So this gives you a score of 3. What does a score of 3 mean? So they kind of have your risk category. So you calculate their risk score based on what we just talked about. So our patient falls in this low risk category. And so what does low risk category mean? So now we can kind of, based on a bunch of data, thousands of MDS patients, they've put together kind of this calculator that tells us, well, if you're low risk, your median survival time is going to be 5.3 years, and that your risk of transforming into AML will be about 10.8 years. So it's pretty interesting. Also, there is an MD calc for this, so it's much simpler than having to look through these separate charts. So I kind of, if you're interested, I would just Google it, the MD calc IPSS-R, and it's kind of interesting to play around with. So now I just kind of want to touch upon these MDS prognostic markers. I've kind of mentioned quite a few. So, we've got kind of the genetics of the MDS. We've got, disease-related variables. So how severe are their pancytopenias? How bad is their dysplasia? Then certainly any sort of comorbidities are going to portend a poor prognosis. So patients that are kind of obese, have had previous chemoradiation, heart failure, renal failure, this all has to come into play when you're deciding whether or not you're going to pursue treatment for MDS. And then certainly for our patient population, performance status is incredibly important. So patients that we're going to treat are really patients that have very, very good performance status. This is your robust 75-year-old with very few comorbidities. And then I will just touch upon this briefly. It's a little bit extra, but there are these MDS, MPN overlap syndromes. So these are myeloproliferative neoplasms. So you can kind of present with a little bit of both. These portend a much poorer prognosis compared to just being diagnosed with MDS. versus just being diagnosed with MPN. And here's are just a few. So we've kind of gone over diagnosis, we've gone over prognosis and calculating risk. So what treatments do we have for this? So MDS is only curable with a stem cell transplant. So the goal for a lot of our patients will be kind of maintenance treatment to prevent them from transforming into AML, maintaining their quality of life, maintaining their functional status, and really, really treating their symptoms. That's probably the hallmark of treatment for most MDS patients. And then just to note, long-term survival is not improved by treating asymptomatic, low-risk myelo kind of MDS patients. So those patients we're just going to monitor. And then, so why would you treat a patient with low risk who's older? So a lot of times these patients are going to develop symptomatic anemias, symptomatic thrombocytopenias, neutropenias. So we're really going to focus on symptom treatment, and there's some cool treatments for this. And then, of course, if a patient is high risk and they're otherwise incredibly healthy at baseline, these patients will need to be treated as they will likely transform to AML or suffer such severe pancytopenias and die from complications of MDS. And I just want to note that severe neutropenia, so this is an ANC less than 500. So you can use kind of your Neupogens and your Neulastas to increase your ANC, but it actually doesn't decrease infection risk or increase survival in MDS patients. So you're really only going to be giving patients this if they have severe neutropenia or if they're very symptomatic with recurrent infections. So how do we treat these low-risk MDS patients? So once again, the goal is to treat symptoms and improve quality of life. So typically these patients, they end up transfusion dependent. So you have your supportive therapy. So these will be repeated blood cell transfusions. And a lot of times when patients are relying on blood transfusions, they're going to need an iron chelating agent to handle all the iron overload from repeated transfusions. You can certainly give them antibiotics for recurrent infections, but there are some other ways to kind of manage these terrible symptoms of MDS. So for symptomatic anemia, so if your hemoglobin is less than 10 or you're already transfusion dependent, you're going to check an EPO level. And if an EPO level is less than 500, you can actually give them EPO. You want to give them the lowest effective dose, and your target hemoglobin would be between 10 and 11.5 to decrease your risk of thrombosis. And then for a patient whose EPO level is greater than 500, that means that, their body recognizes they have abnormal cells. They're trying to stimulate their bone marrow to make healthy cells, and it's just not working. So EPO is not going to work in them, but you can consider some targeted therapies that I'll touch upon. And then for patients with thrombocytopenia, they should be treated for platelets less than 20 or less than 50 with bleeding. And so we can give them thrombopoietin receptor agonists. So these are kind of your Nplate, Promacta, Doptelet. And these are kind of to boost platelets and have them not be relying on platelet infusions. And then if you have multiple cytopenias, so multiple cell lines are down or significant neutropenia, you can also consider targeted therapy. And just for perspective on what a burden, this can be on the healthcare system, and more importantly for patients who are transfusion dependent. So platelets only live about 7 days. So with 1 unit of platelets, you can expect their platelet count to bump 45,000, best case scenario, but that's going to wear off within a week. And then for red blood cell transfusions, so RBCs typically last anywhere from 7 to 28 days. And 1 unit of packed red blood cells should raise your hemoglobin 1 gram, best case scenario. So this would potentially require transfusions nearly every 2 to 3 weeks. So this is a pretty significant burden. So if we can kind of decrease the amount of transfusions, I think it really improves patients' quality of life and certainly decreases kind of burden on the healthcare system. And then kind of interesting, if you're giving kind of these patients that have an EPO level under 500, you're giving them EPO and the kind of effect starts to wear off, you can then add Neupogen or Neulasta, these GCSF agents, and that will actually help to boost hemoglobin. There's some sort of synergistic effect. So what are some of these specialized therapies? So this is a new drug, luspatercept. It was approved in April of 2020 for low-risk MDS to intermediate-risk MDS with ring sideroblast. So these are one of the subtypes in that World Health Organization criteria. And it's a subcutaneous injection given once every 21 days. And it can cause a median increase of 3 grams per deciliter in hemoglobin over 3 months, which is pretty significant. And in a study kind of published in the New England Journal of Medicine, they found that nearly a third of patients became transfusion independent. And so kind of just to elaborate a little bit more on this study in New England Journal of Medicine, it was published back in January of 2020. And they basically found, so of the 153 patients who received luspatercept, 38% were transfusion independent for at least 8 weeks, compared to 13.2% in the placebo group. And then 28% of patients in the luspatercept group actually maintained transfusion independence for 12 weeks or longer, compared with only 8% in the placebo group. And the median duration, so basically the longest continuous period of response to luspatercept, which was transfusion independence, actually lasted for 30 weeks. And then kind of what are some side effects of this drug? Because that's always important. So the most common are fatigue, headache, MSK pain, arthralgia, dizziness. So something we want to consider in our patient population, given their increased risk of falls. But a majority of patients in this study tolerated the side effects pretty well, and the side effects significantly decreased after the 4th cycle of treatment. And just to mention the demographics of this trial, the patient makeup, 80% of the patients in this trial were over 65, and 36% of patients were actually over the age of 75. And then another treatment is lenalidomide or Revlimid. So this is approved for treatment of MDS with cytogenetics that show that deletion 5q. So this is a low-risk MDS. Same idea as the luspatercept, effective at reducing RBC transfusion dependence. So 67% of patients remain transfusion independent for 8 weeks, and this typically recurred after 3 months of treatment. With 50% of patients remaining transfusion independent after a year on therapy. The median increase in hemoglobin in those who did respond and achieve transfusion independence was around 5.5. And this is nice because it's a 10 milligram tablet taken daily for 21 days out of a 28-day cycle. So you take it for 28 days and you have 7 days off. Side effects here are grade 3 or 4 hematologic toxicity. So we're basically seeing exactly what we're trying to prevent. So severe thrombocytopenia and neutropenia were kind of the biggest findings. But this once again tended to subside after, I think, about 2 cycles of treatment. And then just briefly, there's also immunosuppressive agents. So these are your antithymocyte globulins and cyclosporines, which also showed kind of some response rate in low-risk MDS patients. So what about stem cell transplants? So kind of in recent years, you've had development of reduced intensity conditioning and non-myeloablative regimens, as well as more accurate HLA typing methods to make stem cell transplants more tolerable. So there actually have been stem cell transplants in older adults. And I found this study that actually looked at kind of the trends and outcomes of allogeneic hematopoietic cell transplant, so kind of hematopoietic cell transplant, HCT, in adults 70 years and older who had hematologic malignancies. And so this looked at cases in the United States between 2000 and 2013. And they looked at overall survival, progression-free survival, and transplant-related mortality in this group of patients. There were about 1,100 patients who were over the age of 70 who underwent stem cell transplant across 103 transplant centers in the United States from 2000 to 2013. And AML and myelodysplastic syndromes represented the most common disease indication for stem cell transplant. And they found that the 2-year overall survival in patients over the age of 70 and progression-free survival did improve from 2000 to 2013. So their overall survival went from 26 to 39%, and their progression-free survival went from 22% to 32%. And this kind of compared 2000 to 2007 versus 2008 to 2013. So our technology is getting better. Older patients are able to tolerate it. It's still a very, very severe treatment. And I will say that in this study, the 2-year transplant-related mortality ranged at about 35%, and there was no difference in kind of the severe side effects leading to death in stem cell transplants in older adults between 2000 and 2013. So we still have a lot of work to do to make these therapies more tolerable, but we're taking a step in the right direction. And then kind of just briefly, because I thought this was interesting, there are current clinical trials for treatment of low-risk MDS. So vitamin C is kind of once again back in the arena with this theory that it maybe enhances endogenous demethylation. And then interestingly, sertraline. So there's this study that's kind of looking at patients who are on antidepressants. So there was a study where patients who are on antidepressants with SSRIs who were also treated for low-risk MDS. And the patients on sertraline, and actually antidepressants in general, but sertraline had kind of the most significant findings, that they actually had better survival. So once they saw this, they decided to kind of look into it more. So there's currently a trial with MDS patients and sertraline. And so then what do we do for these higher risk patients? So the first line treatment are going to be your hypomethylating agents, so azacitidine and decitabine. And typically these are just going to be used in high-risk patients. The only time they're used in low-risk patients is if they have severe symptoms that we're just not able to treat with our other therapies. In fact, the phase 3 trial of the azacitidine in low-risk MDS was closed due to excess toxicity. So these really shouldn't be used in low-risk patients unless you have to. And kind of just to refresh your memory, in cancer, you basically have excessive methylation of DNA nucleotides within tumor suppressor genes like TP53. So these drugs up here are going to work to reverse methylation to promote an anti-tumor effect. And recently they approved a oral azacitidine and oral decitabine treatment. So it's no longer IV, which is kind of good news because much easier for patients. And they found response rates that are about 30 to 40% in high-risk MDS patients by reducing the risk of transformation to AML and once again, decreasing transfusion dependency. And then I just will briefly touch upon the AZA-001 trial. So this was kind of a big phase 3 international multi-center controlled open label trial of patients with high-risk MDS, and they were randomly assigned treatment with azacitidine versus conventional care. So conventional care included best supportive care, low dose cytarabine or intensive chemotherapy. And they found that in patients with higher risk MDS or AML compared to the conventional care, azacitidine prolonged overall survival and the time to AML transformation. Also improved 2-year survival rates and these hematological response rates. So you saw less RBC transfusion dependency. And I just kind of included a slide with some of this data. They also found that significantly more azacitidine recipients compared to the conventional care achieved RBC transfusion independence at 45% in the azacitidine group versus 11% in the placebo or in the conventional care group. And then of course you have to take into account that patients in the conventional care arm were getting intensive chemotherapy. So these are older patients getting incredibly intensive chemotherapy. And then how tolerable is azacitidine? So once again, you're going to have these hematological side effects of neutropenia, anemia, and thrombocytopenia, which is counterintuitive since that's what we're trying to actually treat. And this was most pronounced in the first or 2 treatment cycles, but then improved significantly with continued treatment. And then constipation was the most frequently reported GI side effect, but kind of the authors of this trial attributed this more to the first 2 cycles where patients were more nauseous and had to have more antiemetics. So basically, if you can get through the first 2 cycles, these adverse drug reactions improve and you should start to feel better. But what I really thought was interesting about this trial was they actually included a quality of life measurement. So they assessed this by telephone interviews. They conducted it at baseline, 2 months, 3.5 months, and 6 months. And they had patients kind of answer the standard surveys of quality of life. And the data showed that patients treated with azacitidine demonstrated improved quality of life compared with those in the conventional care arm. So they had improvement in fatigue, dyspnea, physical functioning, and decreased psychological distress. And in that conventional care arm, there were people that were just getting kind of supportive treatment with infusions. So that's something to take into account. It's not just comparing to people getting intensive chemotherapy. And so kind of just to wrap up with a fun fact, elephants don't really get cancer. That is something I discovered putting this presentation together. So researchers discovered that elephants actually have extra copies of cancer-fighting genes, specifically TP53. So humans only have 2 copies, and elephants, they think, have over 40. So that's pretty interesting. So they are studying elephants as a way to cure cancer. So that was a lot of information, but some takeaway points. And to wrap up, is that, just make sure that MDS is on your radar when you're looking at patients who have unexplained macrocytic anemia, for which you've ruled out all those usual suspects. If you have an abnormal peripheral smear, refer them to heme and get a bone marrow biopsy. And then don't forget about the supportive treatments to reduce transfusion burdens, especially in these symptomatic low-risk MDS patients. Feel more comfortable discussing kind of prognosis with patients using that IPSS-R calculator. So I hope, look at MD Calc. It's actually pretty interesting. It's really simple. And then I hope you feel just a little bit more familiar with the drug treatments for MDS, and maybe you'll feel more comfortable kind of discussing pursuit of these treatments, certainly in your robust, healthy, older patients who have been diagnosed with MDS. And then this is just my references slide, and that's all I have if anyone has any questions.
Thanks, Chris. That was a great presentation. Appreciate it. Any questions? Let's see, here's one coming in from the chat. Thanks for the fun fact, great presentation. Is there a particular geriatric assessment that you recommend for sharing to a hematologist consult?
Yeah, so that's a great question. So there isn't necessarily a specific one, although I did come across kind of a review article that I think was at the University of Chicago, where they put together this very kind of comprehensive geriatric assessment that was created by geriatric oncologists. So Hillary, I can track that down and send it to you, but there isn't kind of a specific one that's commonly used for MDS.
All right, another question is that you mentioned HIV as a risk factor, and is that treated or untreated HIV?
So it's actually both, essentially. So untreated HIV, absolutely. And then treated HIV, it will be a side effect of therapy itself, but these aren't necessarily risk factors for MDS. These are just causes of macrocytic anemia that you want to rule out.
And then a comment that I've seen patients sent to heme, but often they don't get a bone marrow biopsy. So
that's surprising, because that's certainly not kind of what I came across researching all these recommendations. And I don't know, that might be multifactorial. There may be other tests they want to run and they're able to rule it out, but I don't know. Good point. I'll look into it.
And then another question, do you know how the new agent luspatercept works? I probably mispronounced that. But.
So I'm not exactly sure. Great question. The mechanism of action, yeah, I'd honestly have to look into it. But it's kind of working as some sort of agonist, so similar to EPO, but more directed.
Great. Any other questions before we wrap up? Okay. I don't see any other questions. So thanks everybody for participating this morning. Please check your email for the link to the presentation, as well as take a minute to fill out the evaluation. And Dr. Azelby, thanks so much for presenting. It was a really great job. Thanks.
Awesome. Thank you, everyone. Have a great day.